Hey, I need a gurney here! Now! Gurney!
The patient has gone into a seizure here. The rhythmic jerking of limbs indicates the clonic phase of the seizure, which seems to be a generalized tonic-clonic seizure here, which follows a tonic phase first, with generalized stiffening of limbs, with arms flexed and legs extended with the eyes deviated upward or laterally. Apnea or lack of breaths and cyanosis may occur briefly as well. There could also be clenching of jaws with risk of tongue biting. There could also be frothing at the mouth or involuntary urination. This then transitions into a post-ictal phase with flaccid unresponsiveness, confusion, drowsiness, headache, and post-ictal amnesia, meaning no memory of the seizure. Immediate management here would include protecting the patient from injury and ensuring patient safety. We shouldn't restrain the patient's movement and let the seizure run its natural course. We can loosen the clothing of the patient for comfort. Maintain airway, breathing, circulation, and administer oxygen and monitor vitals as soon as possible in a hospital bed.
You sent labs?
No indication, normal vitals, normal neuro exam. Dude just dropped, no warning.
What's open? Trauma 1. Grab Langdon or whoever else is available.
What do we got?
Seizure in chairs.
Thank you. How is it out there?
Chaos. We're never gonna catch up.
The first thing to note here is the froth coming out of his mouth, a typical feature of seizure. However, the most important thing to note here is that the patient is still having convulsions continuing till now since the hallway, and still there is rhythmic jerking of his limbs. This is a very bad sign because if this lasts for more than 5 minutes, the patient is said to have gone into status epilepticus. Status epilepticus is defined as a seizure lasting more than 5 minutes or recurrent seizures without recovery to baseline consciousness between the episodes, meaning if the patient has 2 or more episodes and remains unconscious in between. This is a life-threatening neurological emergency because prolonged seizures can cause permanent brain damage. So here, immediate seizure control must be done. Here, put the patient immediately in oxygen, open up an IV access, and provide IV benzodiazepines like lorazepam.
Lorazepam's on board.
Okay, drop another 4.
The first-line drugs for acute control of status epilepticus are drugs like lorazepam or midazolam. Sometimes, opening an IV access in an actively seizing patient is a huge challenge, and time is brain. So, we don't wait for that and provide intramuscular midazolam 10 mg stat if IV access is difficult or takes time. We would then typically use other second-line drugs as we go if this isn't controlled by lorazepam or midazolam initially.
Yeah, no history. Doesn't look like he's been here before.
Starting low 90s on 5 liters.
If the patient has progressively decreasing oxygen saturation during seizure, it could indicate airway obstruction. Now this could be due to tongue prolapse, secretions buildup obstructing the airway, could be indirectly hinted here by the froth coming out of the mouth, or just hypoventilation as the respiratory muscles can fatigue during seizure. So we gotta secure the airway here and provide enough ventilation, maybe change the nasal prongs to a non-breather mask as per necessary. The point here is to not delay airway management waiting for seizures to stop.
Another 4 milligrams?
Can't get the top off.
It's just the plastic, not the...
No, I know.
Here, give it to me.
No, I got it.
Okay.
Regarding the dose of lorazepam here, it's 0.1 milligrams per kilograms IV and maximum 4 milligrams can be given per dose. Here, it's going to be repeated twice already.
Ordering CBC, CMP, and a straight cath for a urine tox.
We gotta understand here that status epilepticus can be caused acutely due to stroke or CNS infection or head trauma or even electrolyte abnormality, so full blood workup is a must including CBC, CRP, or C-reactive protein if infection is suspected, along with CMP or comprehensive metabolic panel which includes glucose, electrolytes like sodium, calcium, magnesium, liver function tests, along with tests for renal function. A toxicology screen is very important because this could also be due to drug overdose or alcohol withdrawal or accidental ingestion. Urine toxicology screen is the most commonly used as it's quick and detects drugs or their metabolites excreted in urine. A straight catheter, also known as an intermittent catheter, is used to collect a urine sample for toxicology testing when a clean catch urine sample is not possible. It's called in and out catheterization because it's a one-time sterile method to obtain a urine sample without leaving a catheter indwelling like a Foley's catheter.
Pushing the second 4. If this doesn't work, we need to prep Keppra.
Keppra is the brand name for levetiracetam. So if lorazepam doesn't work, there are drugs that can be given like fosphenytoin, sodium valproate, or levetiracetam. These are anti-seizure medications given intravenously as second-line drugs for seizure control in status. Now, if even these fail to control seizure, we gotta start intubation with general anesthesia with either midazolam infusion or propofol infusion or thiopental infusion. At this point, it requires continuous EEG monitoring and ICU care. I've seen a patient who had to be on an infusion of midazolam because his seizure wasn't controlled by lorazepam or levetiracetam and the seizure lasted for more than 30 minutes. It's really a dangerous sight to behold both for doctors as well as for the patient party if the seizure isn't controlled immediately and patient continues to seize again and again despite providing medication for it.
No, we'll give more lorazepam. It's already ordered.
He's already had 8 milligrams. He'll stop breathing.
Then we'll intubate. Sometimes the patient needs a little more.
The girl is actually right here. We can repeat 4 milligrams of IV lorazepam, that too once, after 5 to 10 minutes ideally, if seizure persists and the patient hasn't responded. So maximum total dose would be 8 milligrams in most adults. If seizures are continuing after 2 doses of lorazepam, we shouldn't keep giving it repeatedly after that, as there is risk of respiratory depression. The benzodiazepine drugs like lorazepam or midazolam can cause respiratory depression, and the patient could go into apnea if higher doses are administered sequentially, and yes, that might require intubation to prevent respiratory failure and hypoxia due to benzodiazepines. So, if seizures continue after 2 4 milligram doses of lorazepam, switch immediately to a second-line anti-seizure medication like fosphenytoin, sodium valproate, or levetiracetam.
How long has he been seizing?
About 4 minutes ago.
We know the significance of timing of the seizure here. If it's more than 5 minutes, the diagnosis of status epilepticus is made, and we are treating it as a case of status already here.
He started seizing in chairs. He's already had 8 of lorazepam. I want to move on to Keppra, but Dr. Langdon disagrees.
Just want to try another 2 milligrams before moving on.
Not only does the risk of respiratory depression rise sharply after 2 doses of lorazepam, but also it becomes ineffective due to desensitization of GABA receptors, which is basically the site of action for these drugs. If 8 milligrams didn't work, in theory, adding 2 milligrams is unlikely to make a difference, as benzos lose efficacy over time due to GABA receptor internalization. More benzos mean more sedation but not more seizure control, and more sedation means more risk for hypoventilation and apnea. Let's see what happens here.
Dr. Langdon's patient, Dr. Langdon's call.
The girl can't do anything here except complying to the senior's order, even though she is reasonable here. And honestly, the optimum dose for anything varies according to the treating doctor, as every doctor has different experiences with the patient and drugs. Dr. Langdon might have had a patient controlled before with higher doses of lorazepam than the protocol says, and hence he's insisting for it.
Another 2 of lorazepam.
For a total of 10.
I'm well aware.
As said before, with such high doses of lorazepam, respiration needs to be monitored very well. But the problem here is that the patient is still seizing. It's important to stress here that continuous seizure can permanently damage the brain.
He's still seizing. Call respiratory. I'm setting up an intubation chair.
Which he won't need.
Intubation while the patient is in status epilepticus is an interesting consideration. As we all know, intubation is all about securing the airway and ventilating the patient to minimize the work of breathing and bring back oxygen saturation. But here, the patient is seizing, and it's definitely a challenge. We gotta anesthetize the patient first with general anesthesia before that. Now, the protocol for management of status does include general anesthesia as a last resort. Here, the patient has been given first-line drug lorazepam, and the seizure hasn't stopped. The next best step would be to provide a second-line drug like levetiracetam, fosphenytoin, or valproate. If seizure still persists after that, we call it refractory status, in which case general anesthetic infusion has to be considered to sedate the patient with drugs like propofol. At this point, we have no other choice than to intubate the patient. So, in this case here, we've just repeated the first-line drug. The response has to be assessed over 5 minutes. Then if not, second-line drugs are still pending, so intubation need not be considered immediately here. Let's see.
Dr. Santos, what is the definition of status epilepticus?
Seizure lasting more than 5 minutes or at least 2 seizures without full recovery in between.
Excellent.
Seizure activity has stopped.
So, a little bit of extra lorazepam above the maximum limit actually worked here. In real life scenario, it is important to note that while this might be done based on the experience of the treating doctor, I have seen a case in the ICU where a patient who seemed agitated and causing a bit of trouble was given a little bit of IV midazolam, which was in the already loaded syringe by the nurse in charge without consulting the resident doctor. Here, the patient actually went into respiratory depression and apnea, and we were called immediately. We started CPR, but to no avail, and sadly, the patient who was actually improving in the ICU died.
Also excellent. Spontaneous breathing, good tidal volume.
Tidal volume basically means the amount of air inhaled or exhaled during a normal breath. Its range is from 400 to 500 milliliters and is measured via spirometry. Here the doctor means to say the lungs have fully expanded and there is good air entry and exit as per auscultation of the chest areas. It's important to note this because during status epilepticus, respiration is compromised with hypoventilation or apnea, and there is compromised air entry to the lungs and poor lung expansion.
Sats up to 98.
Welcome back, Mr. Marino.
Now we can do a Keppra load slowly and safely.
Keppra load can be given after status to prevent the seizure recurrence. This becomes important here now because status has a high risk of recurrence. Besides, levetiracetam is a safe drug to use. It provides minimal sedation and can be transitioned easily to the same dose oral later on.
Nice work, Dr. Langdon. I will be at Central if you need me.
This must have been a bad vial. 8 milligrams should have worked.
According to your textbook of emergency medicine, but sometimes they need a little bit more.
Medicine is all about experience, not textbooks. Even though textbook deductions and protocols are the standards to follow, administration of drugs in the recommended doses sometimes do not bring about the expected clinical outcome. And a little bit of dose adjustment is pretty common, and it also varies according to the patient too. While this patient required a higher dose for control, status epilepticus of the next patient may immediately respond to just 4 milligrams of lorazepam as well. So medicine is unpredictable, and we do make practical deductions like Dr. Langdon here as we go and as we come across more cases, sometimes contradicting the standard protocols a little bit.
Or you'll learn that with time.
But why couldn't I open the vial?
Because you're an intern who also needs to learn to trust her senior resident, especially in front of an attending.
Yeah, so her telling Dr. Robbie about the resident's decision sounded so wrong. Like, how could you complain about a senior's decision to another senior in front of him? That's pretty disrespectful. And I don't think this really happens in real life. We don't try to override a senior's decision in front of an attending. The best we would do here as a junior is ask why, and maybe the senior would talk about his past experiences with patients that influenced his decision now. That's it.
Now, check his labs, babysit him until he goes to CT, and get some blankets on these side rails as a seizure precaution.
This ties up perfectly with the causes of seizure we discussed before. There could be a stroke or mass or traumatic lesion in the brain. To rule out all of this, CT head in case of seizure is very important. Additionally, along with all the blood investigations already sent, a lumbar puncture could also be done if CNS infection is suspected like meningitis.
Got a second?
It's never a second, but shoot.
I think there was an issue with a vial of lorazepam used on our last patient, and it should be reported to the drug manufacturer.
What kind of issue?
The cap was really hard to take off, almost like it was super sealed shut.
I mean, it's easier to accept that you don't know everything, and it's fine to screw up sometimes, rather than just complain about how everything isn't perfect. In fact, most of the things aren't textbook perfect, and it's not a big deal.
I'm worried it could be a bigger issue.
Like?
Like maybe the temperature wasn't properly controlled during transportation and the seal on the vial melted shut, which could mean the medication is compromised.
This just means she can't still accept the fact that the patient's seizure didn't stop with 2 doses of lorazepam as per the guidelines and is blaming the vial or the drug stored in it to be ineffective. It's easier to understand how every patient's body responds different to medications rather than think that the medicine is somehow defective here.
Any other vials affected?
Just this one.
Okay. Check the manufacturer's website, see if there's been a recall of the lot number.
And what if this is the first regular vial?
Then hold on to the vial in case there are any other issues.
The resident is fed up with the intern trying to be smarter than him at this point here.
Little advice, man to man. Always compliment her outfit.
Hold her hand in front of your friends, and always wrap it before you tap it.
Okay.
Just wanted to add this scene here. I love how this series tries to include medical aspect in every scene and educate.
Poor Huckleberry. Not even 11:30 and you've already been demoted.
I only had morgue scrubs left in my size.
And I guess you better not fuck anything else up today, huh?
Why is there always a person as a colleague who thinks they are the best or the smartest and want to show off their unwanted and oftentimes unjustified attitude towards normal people?
What can I do you for?
Hypothetical question. Would you ever go over a resident's head to the attending?
Hypothetically, I wouldn't recommend it unless it's a behavioral issue or harassment. And in that case, you can make a confidential report to HR.
What if it's more patient care related?
Depends. If it's something minor, leave it alone. If it's something that endangers a patient, then definitely yes.
Why would you want to pick a battle with a resident when you are an intern? Medicine is all about experience, and the experienced one knows better than the junior. Period. No matter how smart you think you are or how much more medical textbooky knowledge you have, the experience wins every single time. This is just disrespect to Dr. Langdon at this point.
Pick your battles. You don't want to be the intern who cried wolf.
We, as interns, used to be sometimes angry with the residents because some of them used to make us work all the time, even making us do stuffs that aren't really related to medicine at all, but we never were angry with the residents because they outsmarted us. I mean, they are supposed to know more than us. That's why they are the residents. Some residents are condescending to interns, and I understand that completely. But what's Dr. Langdon's fault here? He seems to be a pretty good guide to the girl who is hell-bent on not being open to newer perspectives, despite almost causing a patient's death due to her own negligence and not informing Langdon about her ordering BiPAP for pneumothorax.